accidentally buried my lapel mic at some point early in the presentation. Questions so far, comments? Okay. So what made Project, we called it Project SafeCare, we just call it SafeCare now, but what made Project SafeCare different? Huge difference was demographics and geography. Rural Southern Illinois, Project 12 Ways, highly dense, highly diverse, urban San Fernando Valley of Los Angeles, California. The most common mother was a Latina, but I would say we had families ranging from Afghanis to Zimbabweans. Los Angeles is the major home to over 60 ethnic groups, where there's the largest population of that ethnic group outside of the native country. So LA and the San Fernando Valley, very, very diverse. Based again on my own interest and realization that we needed to make the 12 Ways model more disseminable, and the funder, the California Wellness Foundation, we had to make it more succinct. So we looked at the three common service modules, meaning the ones that we most used in Southern Illinois, and those turned out to be parent training, health, and safety. And I'll tell you more about that in a minute. So we took it down to 3 modules. We decided we wanted to see if that could be accomplished in 5 sessions per module with success. So the whole intervention was 15 sessions. So you did a couple of assessment sessions, you engaged the family, then you do 1 module at a time of these 3 modules, and then you're out of there. And would that be effective? Because if it was effective, it also suggests it would be disseminable. Another difference between SafeCare and the Illinois project was that in Illinois, what we had was captive graduate students. Who are graduate students? They're very bright, they're very motivated, they're very underpaid. They work for what we might call contingencies that are different from an average employee, and they can get a thesis out of their work. So they're highly motivated. And the particular program that I ran was a very tight behavioral psychology program, so it wasn't very professionally diverse. Purposefully in California and LA, we hired a nurse. We actually were given a DCFS, Child Protective Service worker, and we hired bachelor's level staff who had bachelor's backgrounds in the usual diversity that DFACS here would hire most of the bachelor's level staff. So they more represented, our staff more represented sort of a real community staff than our project in Illinois. So let me tell you a little bit more about what SafeCare looks like today. Within parent-child interactions, we have 2 different modules depending on the developmental level of the child. So we have protocols for parent-infant interactions, and that primarily involves teaching a young parent how to engage their baby, stimulate their baby, and the most critical rule of all, based on 50 years of developmental psychology research, is talk, 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 and talk your head off to your baby, whether your baby immediately understands what you're saying at the moment. There are clear data that the more a child hears language, the more a child's vocabulary grows. The more a child's vocabulary grows, the better social and academic outcomes for that child. And the separation starts to happen early, and then it gets very large if that child doesn't hear a lot of language. And nurturing language, not just telling a child what not to do, but describing everything you can imaginable to a child. Talk, talk, and talk some more. And little rocking, gentle tone, touching. That's what the parent-infant interaction module is all about. Once the child has some receptive language and is usually walking, we move to something called planned activities training, and that truly is all about engagement. I think I do not have a graphic with the details of planned activities training, but I'll tell you a little bit about it. So planned activity training involves teaching the parent to sort of schedule and arrange their own time. And when we talk about activities, we're talking about anything from doing homework with a child or playing ball with a child to daily activities, simply getting ready to go to school, preparing a meal, getting ready for bed. So it's the gamut of activities a child should be engaged in during a day, and it's all aimed at preventing difficult behaviors. So you teach the parent how to manage time. You teach the parent to state rules of activities. You know, we all go through rules all day, every day. We see signs everywhere. First page of this, and what Barbara introduced largely at the beginning was the rules of engagement here. Go get, I meant to get my parking thing stamped at break. Is somebody still going to be there to deal with that? Okay. Get your parking thing stamped. Sign in. There's food over there. You know, don't feed the dog. Whatever. We have rules all day, and it's very helpful to tell the child the rules of an activity. You might find if you did that alone, it would help those of you that are struggling with your own kids or husband. We're going over to the Smiths tonight for dinner. Here are the rules. Don't start talking about my mother. You know, actually, you're supposed to state rules positively. So I should say nice things about my mother if you're going to talk about my mother, and so forth. So, and that's it. That's our parent-child interactions. All of these things are in 5 sessions, not longer, and one at a time. There's some interesting literature that's come out in the past few years. When I funded a little internal study at CDC where we did what's called a meta-analysis, and there's been other studies in the last few years showing more is not better in child welfare, more is not better in child development or in parenting. That the more you try to give at the same time, the more confused the parent gets and the less good the outcomes. You want to do 1 or 2 things at a time, not a lot of things. And so, in fact, of these modules, the referral may dictate which one. There's no rule about which one you do first as a home visitor. The referral dictates it, or the parent dictates it if there's not an urgency with the referral. The parent picks which one she wants to do. You can guess what the most popular one is? It's been a surprise to me till I figured out why. What do you think the most popular of home safety, parent-child interactions, or healthcare is? Are you shy? Is this a ubiquitous shy group? It's actually health. And then it struck on me why. Because health is the hardest, actually. It's the most cumbersome, as you'll see. But it's the least evaluative. Who's going to argue that it would be beneficial to know when to call a doctor, treat yourself, or go to an emergency room? There's nothing judgmental about that. Whereas parenting, interactions, and safety, certainly. I mean, when you look around the house, you say, your place is a disaster, and we got to fix this. That's pretty evaluative. So I think the parents choose health because who doesn't want their children to be healthy? I mean, you got to be pretty troubled if you don't want a healthy child. But in any case, home safety involves a tool we use called the Home Accident Prevention Inventory. And we actually count the number of accessible hazards to the child in a home of the youngest child. So, I mean, there's obviously ones that are accessible to all children, like an uncovered outlet, fireplace without a screen, those kind of things. Illicit drugs, prescription drugs, over-the-counter drugs available on a coffee table to a toddler, sometimes with the caps open, ashtrays, those kind of things. But then climbing also, things that can tip over. I actually only learned this last week that there are refrigerator locks commonly sold in the safety section of Walmart now. And the only reason I learned it is we periodically do expert content validations of our protocols. So and we just completed one. In fact, it was the health module was recently revalidated by pediatric residents at Emory here next door. The safety, I want to say, was state workers through DECAL. I think that's who did our safety, and a couple of DFACS workers. And they suggested that we add refrigerator locks, and I didn't know that they're readily available. So what do you do when you have graduate students? You send your graduate student to Walmart. And I sent her to particularly because my limited range of places I go, I take the train, the MARTA, and I know there's a really big Walmart in Chamblee at Chamblee, Tucker, and Buford Highway, I think it is, or Peachtree Industrial. I don't remember which, but and I figured, whoa, that's a really diverse area too. So she went there, and there's the whole section of safety stuff, and they have very readily available these refrigerator locks. So we're going to add that to the package we give families, thanks to DECAL and DFACS. Something was missing from recently from our assessments and what we do. But so we look at hazards, and we look at filth and clutter. We actually have a tool that comes up with a score for filth and clutter. And again, we had hands raised before of real workers, real workers who know what we're talking about when we say filth and clutter. It doesn't mean your dorm room. A dorm room looks like a model home compared to some neglect families' homes. People in child welfare often refer to them as hard chair homes, meaning you're looking for a surface to sit on that does not have fabric on it, that is hard, so you don't have to worry about what you might be sitting on or what might be living below you when you're sitting. Or you fear that the family's going to offer you something to eat or drink. And what we do with those situations is gradually over the 5 sessions help the family make change. We've had a lot of support actually, quite often from Target, from Hudson Dayton Corporation, which owns Target, will give us safety packets. We don't even have to buy them. DFACS has bought them for Georgia. And I'm going to get around to it, tell you about the statewide Georgia implementation in SafeCare. But so providers who are trained here in Georgia in SafeCare actually bring safety kits with them. And we will be adding the refrigerator locks to the kits. But there's nothing super sophisticated about our home safety component. It's a matter of working with the parent to show them how to assess the safety and health hazards and to go about changing them and giving them those skills. And then the third component is child health care, which has 3 primary goals, and that is to teach when to call a doctor, when to self-treat, and when to make an emergency room visit. And we do this, all of this is done with role-playing. None of this is done with talk. We're going to show you how to do it. Now we want you to do it, and we know you've done it right when you can do it without needing a model from us again, not having us to show you how to do it. And the health comes with an elaborate manual which has all kinds of scenarios of health described where mom learns how to diagnose the issue when she sees it, and then make one of these critical decisions about calling the doctor or self-treating or even deciding what the problem is. I want to tell you 2 quick stories about health that were very rewarding for me to hear. One was when we were working with the Doris Duke Charitable Foundation to try to get a lot of money from them for the National SafeCare Center grant. The project officer wanted to do a home visit here in Georgia. So we arranged with the Cobb County nurses that we trained that the project officer would go to a home and see a nurse doing SafeCare. And we had to get permission from the family, and we had to coordinate it, and then our trainer went out with the project officer, and they got to the home a little bit late because the session had already started. And Mom was talking about health care, and part of health care is a checklist. So we asked that when your baby is sick, you fill out a little checklist to keep track of fever, to keep track of symptoms, to keep track of whatever you've done. So if you were supposed to give Tylenol at this hour, so you know when you did it, and you know when you need to do it next. It's a checklist. Our health is more conservative than most of us do with our kids. Our safety and filth and clutter protocols are more conservative than we usually do with most of our kids. I tell you, my house would absolutely fail with my grandchildren, the home accident prevention inventory. But you want to make it as conservative as possible, hoping that they keep at least the majority of these skills, and that they really make changes that keep them out of trouble. But so Mom's talking to and it was all prevention, the nurses, by the way. There was next to no referrals, or there may have been a couple of referrals, but most of them were just prevention cases in Cobb County. And Mom is telling the nurse that she had taken the child to the doctor because he had a fever that wasn't going away so quickly. And in her own words, as our project officer was walking in to see if she wanted to give us all this money, the mother's saying, so I gave the doc the checklist, and he couldn't believe how thorough it was. He said, "You did this?" And she said, yes, I did. And he said, "Where'd you get it?" And she said, "This project I work with. These people come to my home, and they taught me how to use one of these." And he said, "Geez, wow." And she goes, "Okay, does he have a fever?" And the mother said, this is the mother telling the nurse, she says, I told the doctor if he had a fever, it'd be on the checklist. And then this really other great story I was a part of, in that I was speaking to an organization in Baltimore that serves parents with intellectual disabilities, which is a very high-risk group. I'll tell you a little bit about in our current work and our current plans shortly. But so I had actually met, there was a generation that I had met in a previous time I had been in Baltimore, and it was a mother, probably 21, 22 years old, who had an intellectual disability, and she had a baby who was typically developing, and then her mother, grandma, was a typically developing grandma, just a grandma. So the young mother lived with her mother. Her mother worked. The young mother had lots of good services that were provided in the Baltimore area. She had child care, which is really good and good developmentally for the young child. And she had a work training program she was going through. She was learning job skills. So Mom went to work during the day. The daughter went to her work training during the day. The child went to child care. So my colleague brought Mom and Grandma, just Grandma up to me the day I was speaking, because I'd met the mom the prior year. But she came up. Grandma was limping a little bit, but she said, "Grandma's got a story for you she wants you to hear." And what happened was that Grandma was getting off the bus to walk home from work, walking in the crosswalk, and a car hit her. Knocked her down, but she was not unconscious. She was not bleeding. She felt she was okay. People came up and said, "Are you okay? We're going to call 911. We're going to call the ambulance." She said, "No, I'm fine. I just, bumped my leg. I got to get home because my daughter gets home and her baby get home all at the same time. I got to be home for my daughter and baby." So it turns out that Grandma got home and showed the daughter that she'd been hit by a car, and the daughter whipped out her health materials. Now remember, this is a daughter with intellectual disabilities, and the daughter diagnosed Mom as having a contusion, not a whatever. I don't know this stuff. I mean, I would paid attention years ago to it. I don't know. But anyway, she said you need to elevate it, you need to ice it, you need to do this. So then Grandma, when she got time, went to the doctor, and the doctor knows the whole family. And he said, "Well, you got it right. I mean, I don't really have anything to offer you. It is a contusion, blah, blah, blah." And then Grandma said, "Well, yeah, that's what my daughter said." And the doc said, "Your daughter said that?" He said, "Yeah." He said, And she said, well, she has these people who come to the house, and they taught her this stuff, and the doctor was apparently just blown away. And I thought that was just a charming, those are the things instead of the data that really break your heart, which reminds me, we have a new wonderful video of Georgia mothers, and I should have brought it. I'm not used to it. It took a while to put together, and it'll break your heart. These very young mothers, DFACS young moms, saying really nice things about the program. I got to get that in my thought pad. If you write me if you want, I'll send you the video. So that's the whole ball of wax with two caveats there, and that is we teach home visitors very structured counseling skills and problem-solving skills. The problem-solving involves working with a person to have them describe a problem, to have them come up with potential solutions to the problem, to come up with potential barriers and solutions, what could go wrong with the problem-solving, and then actually pick which one of the solutions they're going to try, and then report back on how it goes. And we use that, if there's time, with some of the things outside of these protocols when possible, but also if we're struggling with a protocol. If mom's just not getting home safety, or she's not getting parent-child interactions, the home visitor will use the problem-solving skills to work through what can we do to help you get this. And staff have reported to us that they really appreciate having those skills also, and to help frame a session. Because those of you who have worked in the field, you know how chaotic it is in a home, and you know that you may have any number of things in mind to try to deal with that day, but if mom's got a crisis, you wind up dealing with the crisis the whole time. And what this part of this teaches is not ignoring the crisis, but how to deal with these things succinctly and frame a session such that you can get multiple things done in a session if needed. Sure. Well, let's wait for the mic. The mic is coming.
And you may be getting to this later, but my question is a couple things. First of all, how are the home visitors different from parent aides that they utilize? The DFACS utilizes a lot here already. Secondly, how did your program interact with DFACS or the target group? The parents in DFACS, is there a target group for your program? And if so, how do we make referrals? And when you talk about maltreatment, when you talk about maltreatment, is there any cutoff point? And the reason I ask that is because we sometimes have, parents who come in and they may, smack their kids around, and then we have others who come in who have committed egregious acts of, physical or emotional maltreatment. So is there a cutoff point in terms of, when your program is most effective? And are there some families or some parents that, because of the nature of the maltreatment, your program is not suitable for?
It's an excellent set of questions. I should have written them down. So keep me on target. Keep me on target if I go up. But the first one was sort of, who are the providers? And I'm prone to say they're providers as usual. So in Georgia, we're training. We trained a handful of DFACS staff who are doing a little bit of it, but what we are charged with and what our contract is for is training all private providers in Georgia who provide child welfare services. Right now, for in-home, for home visiting, SafeCare has been mandated as the practice of choice. So I'm going to describe our train the trainer model. So we could never build the capacity to do it ourselves. So the whole goal is to train trainers in agencies, train them to be trainers, certify them as not just home visitors, but as trainers for each other. And I'll tell you a little bit soon about coaches and how we maintain and sustain what we call fidelity to the model. I may be skipping around, but SafeCare in Oklahoma has been found to be more effective with neglect not ineffective with abuse, but another model called parent-child interaction therapy has been found in Oklahoma to be a little more effective with abuse cases than SafeCare, and with older kids. Well, what I failed to say is we're birth to 5. So we don't take referrals in Georgia, for example, where the target child is older than 5. They do in Oklahoma because they're geared up differently for it. We've seen some pretty horrendous families over the years, and there is no distinction in Georgia between neglect and abuse. So we take the referrals we get, or I shouldn't say we, because we're not the ones getting them. Whatever the agency has, whatever private agency, I should start learning the names of the agencies, because I frankly don't know the name of any of the agencies. Pardon me? Is that one of them?
Contract with Family Ties to provide NFP services or our intensive family preservation services.
Okay, and I guess that is what would be of interest in terms of what agencies or providers here in Georgia are utilizing the SafeCare model.
It's actually on their website. It's on the website.
On what
Can we try and get some of these things on the
Actually, I'm using the ceiling mic that I just installed, so I think
The website will be on the last slide. You've got it. It'll be on the last page. And you can learn if you drill through the website, you can learn an awful lot about SafeCare, because there's all kinds of anything from where services are to articles you might want to read about it, and so forth. Oh, sure.
I have a question. So what happens with a family, and this may be a defects question, but what happens with a family that has the population 0 to 5, maybe 1 or 2 kids, but then there are older kids in the home that they're also having challenges with? Because, I mean, we're talking about pre-adolescents, adolescents, and teens, which is a great need. I have 4 at home, so I know that, it can be challenging. So what happens in a case like that?
We do not serve that age group, and I don't know.
What we do is to do a referral to intensive family preservation if needed, and they come in and they work for a specific time, and they target whatever you put on that referral. Of course, once they go in, they'll do an assessment, and based on what you have on your referral and what they see, they can, correspond back and forth with the defects case manager to determine what's best for that family.
So is this set up to interact with families before they come into the defect system?
Both.
Okay.
Both. We have diversion cases, we have prevention cases. There is, I don't know when I was planning to say this, but I'll say it now. In 1979, when I wrote this grant, there was only one other systematic home visiting service I know of that had begun around then, and that was Nurse Family Partnership, of which you may have heard, which is run by David Olds, or founded by David Olds. And today, in the United States, the current administration has put $1.5 billion toward home visiting over the next 5 years. For the first year, it's a mere $400 million, and it's being allocated to 49 states. Why Wyoming didn't apply, don't ask me. But and that's primarily primary prevention. So those monies are going to be for home visiting, for evidence-based programs. The Department of Health and Human Services, through HRSA, which is, I never remember what it stands for, but the first letter is health. Through HRSA and through ACF, the Administration on Children and Families, is finalizing the criteria for evidence-based practices from which the states can choose. And a state could choose to offer just one or a panoply. I shouldn't say a panoply because there's not a panoply of evidence-based practices, but among the relatively few evidence-based practices. If I were a state, I would, unless I was a very small state, I would never consider giving it to one evidence-based practice, because nobody's going to have the capacity to deal that quickly with all the states. But so we expect, for example, in addition to the training we've been doing to allow agencies across Georgia to have the capacity to provide safe care, we're hoping that we get a chunk of the money. It will be proportional to the population of this. That's all happening right now. The states have made their application. Now they're working on their needs assessment. The criteria will be done, I believe, in this month, and then the states will be told, call for services among these evidence-based practices. We will be very surprised if we don't get a chunk of the Georgia money. And by we, that means, again, just to train as many more agencies as possible to provide prevention services and to focus on the prevention end. But here in this state, right now, with the agencies we have trained, it's both prevention, diversion, and substantiated. It's what comes through. And that's also the case, actually, at this point in Oklahoma, and pretty much the case in California. With SafeCare, that is. So I've mostly gone over this with you. What it looks like is about 6 sessions when you count the follow-up. The principles are based on learning skills, and the delivery is actually very flexible. So it can be intermixed with other services. It can be intermixed with crises that may need to be attended to by the provider. It can be once or twice a week or every other week. It shouldn't be less frequent than that. Sessions usually average around an hour and a half, but of course that depends on the family. So our study in California found that compared, and in Illinois, as you know, compared to usual services or no services, SafeCare was superior. Our study in California found that SafeCare reduced child maltreatment reports as much as 75%. In 3 years. We've got a number of studies in several states now looking at individual behavior change, looking at one service or not. For example, we've got a study in Kansas looking just at just at planned activities training, just the older child behavior management piece, and giving mom a cell phone and texting her daily. Very simple texts, not always to do with child maltreatment, or child behavior, but staying in touch with mom, and then having one scheduled phone chat a week besides the once-a-week home visit. And that study has looked at services as usual, safe care without cell phones, and safe care with cell phones. Now, in terms of child and mother outcome, there's no difference between safe care with and without cell phones, because safe care tends to be effective. But what's really fascinating is one of the biggest problems in child welfare is parent attrition, parents dropping out, not being engaged, and there's a very large difference with the cell phones. If mom's got a cell phone, she stays in the intervention. And that's got some very important implications for all human services. In one of the studies we found in Illinois is that there's lower risk for children, lower parental depression, and perceived more social support from safe care than services as usual. And also, families are much easier to engage in safe care than services as usual. And this is something very important for policymakers and state agencies. As with the cell phones producing more retention in the moms, we have higher satisfaction among the providers who are trained and use safe care, and half the attrition of providers. So the turnover is about 35% with service as usual providers in Oklahoma, and only about 15% with safe care. And you know the problem in Georgia and many other states, turnover is remarkable. And in fact, in Oklahoma, basically when somebody turns over from safe care, it's either for a promotion or because they're leaving the area or changing careers. So we've been very pleased with those results. And they also suggest that they're less emotionally exhausted workers who have the structure of safe care and the supervision of safe care. Those are the data from California that I was alluding to. You call this a survival curve, and all it means is after 3 years, either first-time reports or recidivistic reports, there were only, well, if you talk about survival, and that is the lack of reports. 86% survival, meaning 14% reports, 86% no reports after 3 years. The family preservation group after 3 years was, well, that's lower than I thought, actually. Is that right? Yeah, no, it's where I'm standing. 54% survival, 46% first-time or recidivistic child abuse. These are the data that really launched SafeCare in sort of the national perspective. Here's just some examples of individual behavior change using direct observations, and you don't need to know anything about this other than to see that mom didn't have a lot of the skills that we were looking for in parenting until the intervention. This happened to be a video intervention because we were curious to see if we could teach some of these skills using video. And you see mom had about 90% of the planned activity skills after training and also after some time after training. And this was a dad who had asked for help, and he really maintained his skills nicely also. These are healthcare data. We have a dad in here too. These are 3 different parents in 3 different homes, and you see that this is their ability to make these judgments about call a doctor, go to the emergency room, self-treat, and you see after a few months after intervention, they're really maintaining their skills, which is what we want to see. Here's the most recent study done right here in Georgia with an iPhone. And what we did with the iPhone, we wanted to know if an iPhone could possibly cut. One of our big goals with our national center is to make it cheaper, more effective, and more efficient. The training, the outcomes, everything. That's the goal, is to keep studying it, trying to get it better. We wondered if we could use the iPhone as an assessment tool for home safety, rather than the home visitor having to go each time to count the hazards in the home. Could mom use the cell phone to scan it, then send it to the home visitor, get feedback from email or texting, and cut down the number of sessions? And actually what we found was that it looks like we can probably cut out now it's too expensive right now for every mom to have an iPhone. Most moms have cell phones, but to have an iPhone, but they're coming down drastically in price. I know they used to be about $500. I just got my wife one last week that we can't figure out how to use, of course. But maybe SafeCare could come to us. It was $199, but it's the 4G, so it's come down quite a bit. Services are going to be available for just about everybody for just about nothing over the next 5 years. But what we found is that after session 1, we gave which is then session 2 of intervention. These are just 3 different families. We gave mom the iPhone to scan, and the home visitor got these results. These are hazards in the home. And you see they're down to 0 when they started in this family at, on average, over 50 hazards, over 70 hazards, this was in the living room. This one was, this is one family, I'm sorry. This is in the kitchen, and this is in the bathroom. We did this over 3 families. And all those hazards, and then after a couple of months, virtually no hazards in that house. And they actually had to give the cell phone back, so that follow-up was done with mom not having her iPhone anymore. Boy, did they love the iPhones, though. So this is just sort of structurally what our center looks like. It's not very relevant in the moment. I do love this cartoon because it's so true, and unfortunately, it's even true today. So I think this is Dilbert, isn't it? I don't regularly read Dilbert, but I found this. So the boss, somebody's saying, I'm back from training, and he said, I got a big binder. The training's already forgotten, but the binder will last forever, a living monument to contemporary knowledge. So this is an introduction to issues about implementation. And there's your answer. Your answer is this fantastic monograph written by some colleagues of mine called Implementation Research. And it's a study of human services and businesses and how best to train, how best to select staff. For example, we found in Oklahoma that those who most embrace SafeCare, providers who most embrace SafeCare, are not necessarily young in age, but they're young in career. So the fewer years they've been in child welfare, the more they're likely to embrace an evidence-based practice. And there are also people who generally embrace training, practice, and supervision. Not a very big surprise, but an important bit of information. Anyway, I can't recommend this highly enough, whatever your field you're in. If you're trying to implement and disseminate something, and this is free too, by the way, and there's the website for that. So our implementation is to, with as much rigor and efficiency as possible, sustain SafeCare as we implement it broadly. And I'm figuring with this new home visiting money, we'll probably be in a few more states. We've had a number of states contact us. The Army would like, the Army is having a dating game going on with evidence-based practices. They want all their bases in the world to have an evidence-based practice in home visiting, and the National Guard has an interest. So these are serious issues about capacity, about maintaining fidelity. And how do you maintain fidelity? Our approach, and we're not unique to it, is to train trainers, to train them to train, and to train coaches who go in and provide feedback. So for example, in Oklahoma, we found that if a SafeCare provider had a coach, a supervisor, come in periodically and observe a session, give immediate feedback after the session, and a booster training if the person had fallen down on how they were delivering it, we got the best outcomes in preventing neglect. So satisfied was the legislature with that outcome that they are now buying coaches for the entire state. So the entire state of Oklahoma in neglect is doing SafeCare, and it's done with including a coach or coaches who are hired by whatever age, or the legislature pays for the agencies to have coaches. Coaches are part of budgets that are allowable now because they feel it's cost effective. Because if you get that kind of, and it's Oklahoma where we have the retention data on the staff, if you have that kind of retention and you have better outcomes when you have coaches, it pays for itself. We also have, if you're interested, for example, to see what it looks like, go on the website and look at our 2-stage readiness checklist. Because you got to be ready if you want training as an agency. You just can't say, well, I'm the administrator and I want SafeCare. We've got a whole host of things we're going to ask you about what you have and your approach. Do you have a room, for example? That's something, just a basic to start with. Do you have a place to do training? Are you going to provide snacks? Do you have a PowerPoint projector? But beyond that, do you have buy-in from staff? Have you done any kind of orientation with staff? Have you gotten feedback from staff? And a lot of, unfortunately, this kind of preparation that we now have was based on some early, very bad experiences with going in and having the agency just done it as poorly as they could possibly do. People showing up not having a clue why they're there. People who are the wrong people for the training. And let me tell you, from this side of it, it's not fun to face a room full of people like that. So now we presumably prevent that with our readiness checklist. Are people willing to try a new service? I can't figure out the second bullet on my own graph. No NFP without nurses. No SafeCare without. Oh, okay. Here's an example of the kind of rules. So nurse-family partnership, big program. How many of you have heard of it? Very big program all across the country. Fairly rejected in Georgia because of costs, because it does require nurses who are at a premium. And it's a beautiful program. It's a prenatal through 5 years, whatever. It's a great program. And nurse-family partnership, you can't do without nurses. I mean, you got to have nurses. That's a prerequisite. It's end of consultation if you're interested in NFP and you don't have nurses. With SafeCare, we won't talk to you if you're not willing to buy into the whole coaching thing and the fidelity model. Is there adequate reimbursement for a new practice or the referrals from a system? We've had problems in Georgia, I have to tell you. In fact, Georgia, in a lot of ways, has been the toughest of the 10 states we're in terms of money being available for the providers to actually go out and do SafeCare after they've been trained, and a good system of referral. Because one of the last things you want to do is train somebody and have them wait 6 months for a referral. You don't have somebody who's really trained anymore if that's the case, because they've not been getting feedback from a coach. You know how quickly you forget. What's back to that graphic? You'll all walk out the door. Your loved one or somebody will say, "What'd you do today?" "I went to a workshop." "What was it about?" "I don't know." It's about Safe 12. And what's the model look like? It's all nurses. The agent.
I mean, if the agencies want you all to come in and train their people, who pays for that?
It's part of the contract, and it's different everywhere. So in Georgia, the state pays, right? I mean, defects pays, or not defects, but I think the private agency does not pay for training here. It's provided, the state has, the private agency has to have the staff, obviously, and they have to get reimbursed for the service, and that's been a part of the problem. So like we trained some people back in the spring, and there was no money for services. They literally did have to sit around until the new fiscal year to be able to do SafeCare. In some states, some agencies have gotten grants to pay for training. We get grants to pay for training. It's all different everywhere. One of the things we're working on right now is we're going to be going after the Walmart Foundation, who's into dissemination, to try to disseminate our work with parents in several states, with parents with intellectual disabilities. Excuse me. And in that case, if we get the grant, the agencies won't have to pay because they're strapped in the first place. But it's all different everywhere. Colorado, money's coming off a grant. California, the training's paid for by grants or United Way, but again, the services have to be sustained by the agency. So it gets a little complicated.
Just to follow up, Christopher and I were in Tift County, it's bottom of the state, I don't even know when it was, maybe a month ago, and there's a lot of local control. There appears to be that this particular Tift County director said that she had about $30,000 or $40,000 to pay for prevention services that year. And they also, in that Tift County, they had one of the highest repeat maltreatment, so a child had been abused and then re-abused within 6 months in the state. And she was really doing a calculation in her head of, I think it was $4,000 a family, and how many families could she serve? And she said, "I just can't do it." And she said, "So I'm gonna figure," she's like, "I can do more by just buying transportation services for this person," kind of just doing this patchwork stuff rather than investing in these families. But she seemed really frustrated with it. She was working it out over and over on paper.
That's where, for example, the money that should be coming to the state should help. It actually costs, including training, our economists tell us around $2,000 per family, which is cheaper than, for example, nurse-family partnership. But that's why we have this center, is to try to look at technology, we're looking now at having web-based, the didactic part of training, just learning some of the stuff you have to learn by reading, not sitting in the workshop, but by doing it in advance and then getting certified for it. That's going to cut down costs, and that's our goal. Look at our economy nationally, internationally right now. You can't have something that's expensive. Though this administration is certainly committed to prevention in child development. The way we teach parents is absolutely no different than we teach a home visitor or a trainer. And that is, you explain it, you have them take a quiz on it, you model it, you have them practice, you give them feedback until they get it right. They have to meet performance criteria before they move on to the next protocol you want to train. They, again, being whomever we train. Coaches, trainers, home visitors, parents. We do not distinguish. Everyone receives the same model I just described. And then if you're going to have a contract with SafeCare, you have to buy into fidelity, and that is having somebody go out and be a coach who periodically gives feedback to the home visitor. And here's just fairly loose costs. It's about $5,000 to train a home visitor, about $3,000 for a coach, and about $9,500 to become a trainer for an agency. And as I said, it's about $2,200 for a family. Here's where we are today. We're pretty much statewide in Washington State. Some of you may have not done well in civics in school, in Washington State. We've worked in many parts of the state with contracts there, including a place called Epic in Yakima, Washington, in the east of the Cascades, whose primary family is a member of the Yakima Indian Nation. In California, we have research projects and service projects, and we now are going to add 3 more stars, so it'll have to become a big star. We've got funding in California from HHS, we've got it from United Way, we've got it from CDC, and California asked us to come out and talk to them, to several people in the state who are going to be administering their home visiting money. So we expect California should be a big star now. Colorado, we're working with the drug court. We have drug moms, children removed, moms being sent, leaving her incarceration. That's a real challenge, and it's also a research project. I'm very hopeful about what's going on there. North Dakota is where they got a grant to have us train an agency that works with adults with parents with intellectual disabilities. Oklahoma, we've got a rural project, an urban project, we've got the statewide project. A whole lot's been going on for 10 years in Oklahoma. We've just got 2 new contracts in Texas. Georgia, as I mentioned, is statewide. Kansas is where we're doing cell phones. Indiana, we're doing touchscreen computers, which we bring to the parent and then let them have at it with interacting with videos, and even a little cartoon parrot who tells you, his name is Petey, who tells you what to do next. And in Maryland is also in Baltimore working with parents with intellectual disabilities. It's you get your points now. I get my validation. Any last question? Oh, I want to mention technology is the way we're going. And one of the things we're really interested in doing with parents with intellectual disabilities is digital frames. You know those things that run the continuous photographs and videos that many of us have in our homes? I'm thinking that that's a way to get better results. So a parent can have a model all day in her home if she has an intellectual disability. We'll be doing that right here in Metro Atlanta very shortly. And I want to say that no practice is a panacea. SafeCare is not for everybody. We need to get together with evidence-based practices and learn from each other. We just submitted a large grant to Annie E. Casey to combine with another EVP that's here in Georgia called Parents as Teachers, and I really hope we get it, because that's going to take us in a direction we want to go. That's to get a hold of me. Those are the 2 people occupying most of my time the last 11 days, and I'm going to cry when they go home tomorrow. So thank you very much. They're a very nice group, and I'm thrilled to be here.